Next up, preserving your bowel and bladder function. Lasting for more than 3,000 years, ancient Egypt was one of the greatest early civilizations. They had a vastly underestimated knowledge of medicine, which even included medical subspecialties. The pharaohs, for example, had access to dedicated physicians to serve as, quote, guardians of the royal bowel movement, unquote, a title alternately translated from the hieroglyphs to mean shepherd of the anus. How's that for a resume builder? Today, the primacy of the bowel movement's importance continues. Some have called for bowel habits, along with heart rate, blood pressure, and breathing rate, to be considered a vital sign of how the body is functioning. Optimal frequency, as derived in c.nf/BMs, is probably 2 or 3 bowel movements a day. However, the most important criterion for establishing a constipation diagnosis is not frequency, but rather consideration of the most prevalent symptom, straining. Ideally, bowel movements should be effortless. Constipation. Constipation is considered the most common gastrointestinal complaint in the United States, leading to millions of doctor's appointments each year and 800,000 emergency room visits. Older individuals are at increased risk, perhaps due to decreased dietary fiber, fluids, and physical activity. Constipation affects up to 30% of those 65 and older, up to 50% of individuals older than 85, and as many as 2/3 of those living in geriatric care facilities. Other than straining at hard stool and infrequent bowel movements, symptoms of constipation can include abdominal discomfort and pain, bloating, nausea, and rectal bleeding during defecation. Though it can often be benign, any sign of blood from bathrooming should always be something you get checked out by a medical professional. Other red flag symptoms include unintentional weight loss of more than 10% over 3 months, a family history of inflammatory bowel disease or colorectal cancer, jaundice, new onset symptoms starting after age 50, and rectal tenesmus, which is the sensation of being unable to empty your bowels even though there's nothing there. Don't strain yourself. A systematic review of the impact of constipation on people's lives found that the decrease in quality of life was comparable to that experienced by persons suffering from conditions such as osteoarthritis, rheumatoid arthritis, chronic allergies, and diabetes. Despite the shadow cast over everyday life, surveys show that many U.S. adults suffering from chronic constipation have never discussed their symptoms with a healthcare provider. The taboo appears to go both ways, as health professionals seldom pay sufficient attention to bowel function, which has been recognized as a quote-unquote serious oversight of the medical profession by a consensus panel of experts. Even people who don't think they are may very well be clinically constipated. In one study in Ohio, for example, a quarter of the so-called healthy subjects reported experiencing incomplete emptying, and almost half indicated increased straining during defecating, so much so, in fact, that more than half had found blood on their toilet paper within the past year. Straining when trying to pass small, firm stools can certainly cause discomfort, but beyond the pain, firm stools may contribute to a variety of health problems. For example, more than 1 in 5 Americans suffer from hiatal hernias, a condition where part of the stomach is pushed up and through the diaphragm into the chest. Hiatal hernias are uncommon among populations eating plant-based diets who have rates closer to 1 in 1,000. Why such a great discrepancy? Plant-based eaters tend to smoothly pass large, soft stools. If you routinely strain during bowel movements, over time the increased pressure to push out stool can actually push part of the stomach up and out of the abdomen, which allows acid to reflux up towards the throat and cause symptoms like heartburn. This same pressure exerted on the toilet week after week can also cause other issues, including hemorrhoids and varicose veins, as well as anal fissures and other painful conditions. Have you ever squeezed a stress ball? If you have, then you know how tightening your hand around it causes balloon-like bubbles to bulge out. Similarly, the pressure from straining on the toilet may cause pockets to pop out from the wall of the colon, a condition known as diverticulosis. The increased abdominal pressure may also back up blood flow in the veins around the anus, causing hemorrhoids, or even push blood flow back into the legs, resulting in varicose veins. But A fiber-rich diet can relieve the pressure in both directions. Those who eat diets that revolve around whole plant foods tend to pass unforced bowel movements, which results in more than 25 times lower rates of so-called pressure diseases such as diverticulitis, hemorrhoids, varicose veins, and hiatal hernias. As a TMI side note, don't say I didn't warn you. Once when I was showering, to my chagrin, I detected a, posterior lump. How could I, of all people, have a hemorrhoid? I even named one of my guinea pigs after Fiberman Dennis Burkett. After a few more seconds of inspection, I realized that I wished I just had a hemorrhoid. The lump had legs. Thus concludes the story of how I discovered a huge bloated anal tick. Protracted straining can also cause heart rhythm disturbances and a reduction in blood flow to the heart and brain, which may result in defecation-related fainting and even, under certain circumstances, death. Just 15 seconds of straining can temporarily cut blood flow to the brain by 21% and to the heart by nearly 50%, thereby providing a mechanism for so-called bedpan death syndrome. If you think you have to strain a lot while sitting, try having a bowel movement while you're flat on your back. Bearing down for just a few seconds while supine can send up your blood pressure to nearly 170/110, which may help account for the notorious frequency of sudden and unexpected deaths of patients while using bedpans in hospitals. When treated inadequately, constipation can also lead to fecal impaction, which could require emergency hospitalization. Older individuals facing a half-in, half-out crisis may try manual self-disimpaction, removing stool by hand, a procedure that can be painful, distressing, and potentially harmful. The optimal remedy is to prevent constipation in the first place. A sidebar: best pooping position for constipation. What about the influence of body position on defecation? While squatting remains the traditional position in some parts of Asia and Africa, Westerners have become accustomed to sitting on toilet seats. When you sit upright, however, your quote-unquote anorectal angle doesn't straighten enough. That kink at the end of the rectum helps keep us from pooping our pants. In a sitting toilet posture, your poop must make a nearly 90-degree turn, defeating the purpose of this brilliant design. Trying to poop while seated is like trying to drive a car without releasing the parking brake. Check out c.nf/positioning for all the research, but basically we can manipulate the anorectal angle through squatting or leaning to more easily pass unnaturally firm stools, but why not just treat the cause and eat enough fiber-containing whole plant foods to create stools so large and soft that you can pass them effortlessly at any angle. Laxative efficacy. The desperation to treat constipation is embodied by medical gadgets that range from automated abdominal massage devices that strap around your midsection to vibrating capsules you swallow to buzz you from the inside out. More ominously, colectomies for chronic constipation are on the rise. Complications of colon resection occur in approximately 1 in 4 operations, and 1 in 250 procedures result in death. The most common treatments, though, are over-the-counter remedies such as laxatives that cash out in excess of $1 billion in sales every year. Despite more than 100 randomized clinical trials and various constipation treatments, we still lack high-quality evidence on the safety and effectiveness of laxatives in older adults. The stool softener Docusate, for example, which is sold as Colace, doesn't appear to effectively relieve constipation despite its frequent use as one of the most common over-the-counter agents. Stimulant laxatives such as Senna or Bisacodyl or Docalax are only approved for short-term usage of fewer than 4 weeks, but unfortunately long-term use for months or even years is widespread. Biopsies taken from long-term stimulant laxative users show that the nerves innervating your colon can be quote-unquote severely damaged. The over-the-counter laxative with the best safety and efficacy record is probably polyethylene glycol, which is sold as Miralax or Glycolax, not to be confused with ethylene glycol or antifreeze, which can be fatal if ingested. The majority of drugs currently available for the treatment of constipation are generally safe when used as directed, but their effectiveness leaves much to be desired. In a study of more than 1,000 men and women suffering from chronic constipation, the majority taking over-the-counter medication reported little or no satisfaction at all with the drug's effects on their constipation, 62%, or constipation-related abdominal symptoms, 78%. There's gotta be a better way. Smooth moves. There are many lifestyle approaches to treating constipation, such as eating breakfast with a hot beverage to help kick off the gastrocolic reflex, but the holy trinity that doctors preach about most often is dietary fiber, fluids, and exercise. In terms of exercise, population studies don't seem to show a clear association between constipation and physical activity after other factors like fiber consumption are taken into account. But you can't know for sure until you put it to the test. Inactivity does seem to slow things down. When active older adults became sedentary, dropping their daily step counts from about 13,000 down to 4,000, they nearly doubled their colonic transit time within 2 weeks. The time it takes food to get from your mouth to anus can be measured by using the blue poo test with food coloring or just eating some beets. Conversely, even mild physical activity has been shown to reduce symptoms of abdominal distension and bloating. But what about constipation? To date, there have been 9 randomized control trials in adults of exercise for constipation. Even moderate aerobic exercise, such as walking 20 minutes a day, was shown to be able to improve mild constipation symptoms. Though this has not been tested for severe constipation, what about fluids? I review all the interventional studies on increasing fluid intake and constipation in c.nf/mineral water, including the risks and benefits of using Epsom salts, magnesium sulfate, and minerals introduced in the opposite direction via sodium phosphate enemas sold as Fleet. I conclude that the best remedy for constipation may be to treat the cause by ensuring an adequate intake of fiber, considered the first-line treatment for the management of constipation. A fiber deficiency disease. Constipation can be considered a disease of nutrient deficiency, and that nutrient is fiber. Not even 3% of Americans meet the recommended minimum daily intake of fiber, meaning Americans are not eating enough whole plant foods. The only place fiber is found in abundance. No wonder those eating strictly plant-based diets are 3 times more likely to have daily bowel movements. If just half of the U.S. population ate an additional 3 grams of fiber a day, which is like a quarter cup of beans or a bowl of oatmeal, that could potentially save billions in medical costs from constipation alone, based on an estimate that on a population scale, a daily increase of just 1 gram of dietary fiber would lead to about a 2% reduction in constipation prevalence. It's hard to create a shredded wheat placebo, but you can prove cause and effect with randomized, double-blind, placebo-controlled trials using fiber supplements. Fiber supplements. By far the most commonly used treatments for constipation, fiber supplements are recommended as first-line management by American, European, and global guidelines. Soluble non-fermentable fibers such as psyllium, also known as aspagula and sold as Metamucil, are touted as the most appropriate first choice. Psyllium traps water in the intestine, increasing stool water content and bulk to ease defecation, but it's for this very reason that it's important to take it as directed with sufficient fluid intake. Otherwise, psyllium itself can cause its own intestinal obstruction. Check out c.nf/fiber supplements for details on efficacy and potential ancillary benefits. Fiber from foods, not fillers. The best way to get fiber is not from the supplement aisle, but from the produce aisle, and even more so from the bulk bean and whole grain section. In addition to bowel regularity, high dietary fiber intake is associated with a reduced risk of heart disease, cancer, obesity, diabetes, depression, and premature death in general. Every 7 grams of daily fiber intake correlates to a 9% reduced risk in heart disease as our #1 killer. So, would 77 grams a day drop our risk by 99%? That's about how much fiber they used to eat in Uganda, a country in which coronary heart disease was almost non-existent. Heart disease is so rare among those eating traditional plant-based diets in Uganda that papers were published with such titles as, quote, "A case of coronary heart disease in an African," unquote. After 26 years of medical practice in East Africa, doctors finally recorded their first case of coronary heart disease. The patient was a judge who consumed a partially westernized diet in which fiber-free foods such as meat, dairy, and eggs replaced some of the plant foods in his traditional diet. Of course, since eating habits have been westernized across the continent, cardiovascular disease is now the non-communicable disease killing the most people there as well, going from virtually non-existent to an epidemic. The early rarity of typical Western diseases in rural regions of sub-Saharan Africa led to the dietary fiber hypothesis, which suggested that diets centered around whole plant foods are so protective against chronic disease because of their fiber content. Predictably, a multi-billion-dollar fiber supplement market arose. There's a problem, though. They don't work. Fiber supplements can be helpful with constipation, but they don't seem to provide any of the other chronic disease benefits. Indeed, studies associating lower risk of disease and death with higher fiber intake relate exclusively to fiber from food, not from fiber isolates or supplements. This may be because fiber is a marker of healthy whole plant food intake, or because of its role as a smuggler. The primary role of dietary fiber may be to encapsulate nutrients to deliver them to our gut microbiome. Fiber is the brick that builds the cell walls of plants, and those cell walls act as indigestible physical barriers. So when you eat structurally intact plant foods, some of the nutrition remains trapped. You can chew all you want, you'll still end up with nutrients like starch completely surrounded by fiber, delivering sustenance to your friendly flora. Your good gut flora then get to eat not only the fiber, but all the food it's wrapped around, too. Fiber supplements like psyllium, however, fail to carry any bounty to our bacteria and aren't even fermentable themselves, so we may miss out on all the auxiliary benefits high-fiber diets give your microbiome. Flax and rye. Ground flax seeds are an excellent whole food source of fiber. For 12 weeks, constipated diabetics were randomized to cookies containing about a tablespoon a day of milled flax seeds, or flax-free placebo cookies. Not only did the flax improve constipation symptoms, such as defecation, pain, straining, and hard stools, but, compared to placebo, its consumption resulted in an 8-pound weight loss, 25-point lower fasting blood sugars, an astounding 1.8% lower hemoglobin A1c, and a 17-point lower LDL cholesterol. For a head-to-head test between flaxseed and psyllium, another cookie group was added containing 10 grams of psyllium. The flaxseed still won, beating out the psyllium for constipation relief, weight loss, blood sugars, and cholesterol. Flax can also be about 4 times cheaper than even generic psyllium. Flax seeds have also been compared directly to and beat the laxative lactulose, increasing bowel movement frequency from 2 per week to 7 per week, as opposed to 6 per week for the lactulose. High-fiber rye bread with 5 grams of fiber per slice has also been tested, with study participants randomized to 8 slices a day. Compared to white bread with only 1 gram per slice, the fiber-rich rye clearly relieved constipation, increasing bowel movement frequency, comfort, stool softness, and intestinal transit time. The rye group experienced increased flatulence and bloating, however, especially in the first week, but as the gut flora adapted and a balance of gas-producing and gas-utilizing bacteria was established, those symptoms diminished. As an aside, the term old farts may not only be derogatory, but a misnomer. Based on a survey of 16,000 Americans, older individuals tend to wind less often than younger age groups. Prunes and mangoes. Decades ago, a paper was published in the journal Geriatric Nursing titled "A Special Recipe to Banish Constipation," anecdotally documenting the efficacy of an ounce a day of a specific concoction. The basic recipe was 2 cups applesauce, 2 cups unprocessed wheat bran, and 1 cup of 100% prune juice, doled out in little medicine cups for nursing home residents. Such a regimen might only cost about half that of psyllium, calculated at $77 a year versus $147 for the psyllium. But how good is the science on prunes? I reviewed the evidence in c.nf/prune. Basically, 10 prunes a day beat out psyllium in a head-to-head test in terms of stool frequency and consistency, increasing regularity from 2 bowel movements a week to 4 in the prune group versus 3 in the Metamucil group. For context, those eating plant-based diets average about 11 bowel movements a week. With the acknowledged caveat that their study was funded by the California Dried Plum Board, the researchers proposed that prunes should be, quote, considered as a first-line therapy for chronic constipation, unquote. Figs failed, but a mango board-funded study found that fresh mangoes were able to beat out psyllium. Men and women with chronic constipation were randomized to eat either a mango a day or the equivalent amount of added fiber in the form of psyllium, which is about 1 daily teaspoon. At the end of 1 month, not only did the mangoes work better in terms of constipation relief, but the fruit had a significant anti-inflammatory effect, dropping blood IL-6 levels by more than 20%. This is assumed to be due to the prebiotic effect of mango pulp based on mice microbiome studies, which was confirmed in humans in 2020 when a mango a day for 8 weeks was found to significantly increase the abundance of lactobacillus, the good bacteria in our gut. Colorectal cancer. Colorectal, colon and rectal cancer takes 50,000 lives annually in the United States. It's one of the most commonly diagnosed of all cancers. Over the course of their lifetimes, the average person has about a 1 in 20 chance of developing it. Fortunately, it's one of the most treatable cancers if caught early enough, and routine screening has enabled physicians to detect and remove it before it metastasizes. In the United States alone, there are more than 1 million colorectal cancer survivors, and for those who are diagnosed before the cancer has spread beyond the colon, the 5-year survival rate is about 90%. In its early stages, however, colorectal cancer rarely causes symptoms. If left uncaught until a later stage, treatment is less effective and more difficult. In How Not to Die, I recommended getting screened for colorectal cancer starting at age 50, but 45 may be the new 50. In 2018, the American Cancer Society became the first major organization to suggest that individuals at average risk for colorectal cancer begin screening from age 45 instead of 50. The American College of Physicians, however, reaffirmed starting at 50, while the U.S. Preventive Services Task Force, the most prestigious U.S. guidelines organization I mentioned earlier, debated the pros and cons. Given the recent increase in late-stage tumors among those in their 40s, the USPSTF agreed in 2021 that the starting age for colorectal cancer screening should probably be moved up to 45. Quote-unquote early onset colorectal cancer, defined as diagnosis before age 50, still accounts for only about 10% of cases, but that number has increased by 50% since the mid-1990s. The current incidence rate among 45-year-olds is comparable to the rate among 50-year-olds back in the 90s that led to the original recommendation to begin screening at 50. This rise has been blamed partly on the growing prevalence of obesity, though the increased overuse of antibiotics in children may also have played a role. African-American men are at particular risk, as illustrated by the tragic death of actor Chadwick Boseman from colorectal cancer at age 43. Compared to white Americans, Black Americans have a 40% greater risk of dying from colorectal cancer, yet when surveyed, most mistakenly thought they were at lower risk for the disease. The American College of Physicians has recommended that African Americans begin screening at age 40. Scoping out colonoscopies. According to the USPSTF, there are 6 acceptable colon cancer screening strategies. From age 45, everyone should do one of the following screening procedures: get a colonoscopy once a decade, have their stool tested for hidden blood every year, have their stool tested for DNA markers every 1 to 3 years by Cologuard, for example, get a virtual colonoscopy using CT scan x-rays, or have a flexible sigmoidoscopy either 5 years or every 10 years with annual DNA marker testing. Why do nearly all U.S. doctors recommend colonoscopies when non-invasive stool testing appears to be the preferred screening method in most of the rest of the world? Perhaps it's because most doctors practicing in the rest of the world do not get paid by procedure. As one U.S. gastroenterologist framed it, colonoscopy is the goose that has laid the golden egg. See my extensive coverage of colonoscopy risks versus benefits and how not to die to help you make your decision. In the end, the best method of screening is the one you will actually do. Colorectal cancer prevention. Ironically, one downside of screening is what's been called the health certificate effect, in which those who pass their screenings perceive themselves to be certified as healthy and have a reduced incentive to adopt healthy lifestyles. Indeed, those randomized to colorectal cancer screening ended up lowering their intake of fruits and vegetables, which could potentially end up outweighing the beneficial effect of screening. The answer may be to introduce lifestyle counseling as part of the screening visit. While regular screenings to detect colorectal cancer are certainly sensible, preventing the cancer in the first place is even better. The fraction of colorectal cancer cases that might be prevented by colonoscopies and sigmoidoscopies has been estimated at about 30%, but up to 71% of cases appear to be preventable through a simple portfolio of diet and lifestyle changes, such as decreasing meat intake. To hone in on the most consequential lifestyle elements, researchers look to where colon cancer rates are lowest. While colon cancer remains the second leading cancer killer in the United States, rural Africa has 10 times lower incidence. Migrant studies show that the differences in global rates aren't genetic, since it may only take a single generation for immigrants to assume the colon cancer incidence of their new home country. Changes in diet are considered most likely to be responsible, but there are all sorts of changes when you move from one culture to another, from smoking rates to different exposures to chemicals, infections, or antibiotics. You don't know if it's the diet until you put it to the test. Watch my video c.nf/switchdiets to find out what happens inside the colons of African Americans switched to a traditional high-fiber African-style diet and the colons of native Africans given the sad standard American diet. In short, as the lead investigator put it, quote, "Change your diet, change your cancer risk!" Unquote. Based on studies of more than 3 million individuals, plant-based diets are associated with significantly lower rates of tumors of the digestive tract, including cancers of the colon and rectum. Given the quote-unquote stunningly positive impact a diet centered around whole plant foods can have on cancer risk, one commentator concluded, quote, "While it would be unrealistic to expect rapid and profound lifestyle changes in the general population, it is gratifying to have sound, effective advice to offer to those who are willing to take the steps needed to optimize their healthful longevity." Unquote. Urinary incontinence. We've covered the in and outs of preserving your bowel function. What about our bladder? Urinary incontinence is defined as any involuntary leakage of urine. There are two types. Urgency incontinence, defined as involuntary loss of urine associated with a sudden strong desire to urinate, and stress incontinence, where an activity such as sneezing triggers an involuntary accident. Women are affected at 2 to 3 times the rate of men, especially as they age. The number of voluntary muscle fibers in the female urethral sphincter decreases as they mature. This is combined with a decline in the ability of aging kidneys to concentrate urine, and a bladder with reduced capacity, which can also become more irritable and less likely to empty fully. All this may be complicated by delays in sensations of bladder fullness. But a third of people surveyed in the United States believe the myth that incontinence is an inevitable part of aging, but it certainly does become more common as we get older. Over the age 70, 40% of women may be affected, and over 80, the number may rise to 55%. At whatever age, urinary incontinence is associated with a poorer quality of life. What can we do to prevent and treat it? Piss off with diet. One of the reasons women tend to be more affected than men is a history of childbirth. Compared to cesarean section, vaginal birth can triple the future prevalence of urinary incontinence, thought due to the stretching of muscles and nerves during the birthing process. This especially appears to be the case when having children later in life. Obese women are at 3 times the odds of severe incontinence compared to healthy weight women. This may be due to increased intra-abdominal pressure bearing down on the bladder. Beyond observational data, interventional studies show that even modest weight loss may help. For example, the program to reduce incontinence by diet and exercise, or PRIDE trial, randomized hundreds of overweight and obese women to a weight loss program or a control group that just got general educational health sessions. The weight loss program participants lost an average of 14 pounds more than the control group and experienced significantly fewer episodes of incontinence. At the end of 6 months, the frequency of incontinence was cut by more than half in 61% of the women in the weight loss group compared to only 34% in the control group. With or without incontinence, overactive bladder is defined as urinary urgency, often accompanied by increased urinary frequency. More than 1 in 3 women experience an overactive bladder in their lifetime, with an increasing prevalence with advancing age. However, a randomized, double-blind, placebo-controlled trial showed that relief may just be a half a gram of dried cranberry powder away. Bladder-relaxing drugs to control symptoms, like tolterodine or Detrol, are a multi-billion-dollar industry, yet may only reduce average monthly urinations by 16, about 1 less pee every other day. But less than a quarter teaspoon of cranberry powder worked nearly 4 times better, resulting in almost 2 fewer trips to the bathroom a day. And that's without suffering from the drug's side effects, which may include dry mouth, constipation, sedation, impaired cognitive function, rapid heartbeat, urinary retention, and visual disturbances that lead almost 2/3 of users to discontinue taking it. In the popular press, sufferers are counseled to reduce their consumption of so-called bladder irritants, such as spicy, salty, and acidic foods. There doesn't appear to be any published evidence to support this recommendation, but the beauty of safe, simple dietary tweaks is that there isn't any harm in giving them a try and seeing if you feel better. The only 2 dietary components found to be significantly associated with stress incontinence in a longitudinal study of more than 5,000 women were saturated fat and cholesterol, though they may just be proxies for unhealthier diets and or lifestyles. There doesn't appear to be any association between phytoestrogen intake, such as soy or flax seeds, and urinary symptoms. What about cutting down on coffee? U.S. and international guidelines both suggest reducing caffeine intake. This makes sense. Caffeine is a mild diuretic, especially at doses found in more than 2 or 3 cups of coffee, though daily consumers may habituate to the effect. Surprisingly, though, a meta-analysis of observational studies did not uncover any link between urinary incontinence and coffee intake or caffeine more generally. 2 of 4 interventional studies of caffeine reduction found a reduction in urinary frequency, and the other 2 found no noticeable effects, but only 2 of 7 such studies measuring episodes of incontinence found a significant benefit. Again, though, what's the harm of giving it a try? Fluid restriction in general may be counterproductive, as more concentrated urine may irritate the bladder lining and, paradoxically, worsen symptoms of frequency and urgency. I would, however, suggest trying to cut out diet drinks. A head-to-head comparison found that Diet Coke increased urinary frequency and urgency more than regular Coke. The researchers blamed the artificial sweeteners based on in vitro studies on rat bladders showing increased muscle contraction. Jacked in the box. Drugs that inhibit the bladder muscle from contracting can be prescribed for urge incontinence. The average cure rate is nearly 50%, but they have the list of common side effects I described before. This may help explain why only 14 to 35% of people prescribed these drugs are still on them a year later. There are no FDA-approved drugs for stress incontinence, but surgical interventions have a cure rate exceeding 80%. Surprisingly, there's considerable evidence that systemic or oral estrogen therapy may actually worsen incontinence. For example, in the Women's Health Initiative, continent women receiving estrogen were approximately twice as likely to develop stress incontinence within the first year compared to placebo. Topical or vaginal estrogens do seem to help, though, reducing 1 or 2 accidents a day. However, first-line management for urinary incontinence is non-pharmacological and non-surgical, working 5 times better than local estrogens in a head-to-head test: pelvic floor exercises known as Kegel exercises. In 1948, Dr. Arnold H. Kegel published a paper describing a successful therapy for urinary incontinence that involved exercising the hammock of muscles extending from the pubic bone in the front down and around to the tailbone in the back. To find the right muscles, stop urination midstream. The Mayo Clinic suggests you imagine sitting on a marble and trying to lift it up with your vaginal muscles. Contractions held for 10 seconds and followed by at least 10 seconds of relaxation are recommended 30 to 100 times a day for at least a month to start seeing results. For added motivation to stick with it, improved orgasms and sexual satisfaction are a happy side effect of a toned pelvic musculature. Once your pelvic muscles are in shape, you can use the freeze and squeeze technique to suppress the need to pee when urgency strikes or before you sneeze. For urge incontinence, this can be combined with bladder training, which consists of an hourly pee schedule while you're awake, extending that a half-hour a week until you're able to wait 2.5 to 3 hours between each bathroom break. A meta-analysis of 31 studies involving more than 1,800 women with urinary incontinence in 14 countries found that those who are randomized to pelvic floor muscle Kegel training were, on average, 5 times more likely to be cured and 8 times more likely for women suffering stress incontinence. A sidebar, a bit of a stretch. Physical activity has been associated with lower urinary incontinence risk, but the only interventional studies for exercise not exclusive to the pelvic floor are yoga trials. Check out c.nf/yoga trials for details, but basically, compared to a strict time and attention control group involving non-specific muscle stretching and strengthening exercises, those randomized to actual yoga saw significant benefit for stress incontinence, but not for urgency incontinence. Prostate enlargement. Urinary symptoms in older men are most commonly caused by an enlarged prostate gland, a condition known as benign prostatic hyperplasia, or BPH. BPH affects millions of men in the United States, as many as half by the time we're in our 50s, and 80% of men by their 80s, making it one of the most common diseases to affect men in Western populations. The male prostate surrounds the outlet from the bladder, so it can obstruct normal urine flow if it grows too big. This obstruction can cause a weak or hesitant urine stream and inadequate emptying of the bladder, necessitating frequent trips to the restroom. What's more, stagnant urine retained in the bladder can become a breeding ground for infection. Pharmaceutical and surgical approaches. Unfortunately, the problem appears to worsen as the gland continues to grow larger. Millions of American men have undergone surgery for BPH, and billions have been spent on drugs and supplements. Current medical treatments like finasteride or Proscar are clinically effective, but their efficacy is compromised by adverse effects and low compliance rates. Side effects include sexual dysfunction, high-grade prostate cancer, and depression. No wonder men don't like to take it. A study of more than 1 million American men reported the one-year adherence rate at only 29%. Sexual dysfunctions linked to finasteride include impotence, decreased libido, ejaculatory disorders, and gynecomastia, or male breast enlargement. In 2021, internal documents from Merck, the drug company that makes Proscar, were made public thanks to legal action from the Reuters news agency. Turns out that Merck knew as far back as 2009 that his drug appeared to cause persistent erectile dysfunction even after the drug was stopped, but Merck's quote-unquote risk management safety team decided to basically sit on the information. Well, that brings us to the gold standard treatment for BPH, surgery. Procedures involve a slew of different Roto-Rooter-esque techniques with innocent-sounding acronyms like TUMPT, TUNA, and TURP. The T's stand for transurethral, or going inside and up the penis with an instrument called a resectoscope. TUMPT is transurethral microwave thermotherapy, in which doctors use an antenna-like tool to essentially tunnel up the penis and, with microwaves, burn out a shaft. TUNA stands for transurethral needle ablation, which involves burning out a column with a pair of heated needles. And these are so-called minimally invasive techniques. In the gold standard procedure called TURP for transurethral resection of the prostate, surgeons use a loop of wire to core out the gland. Side effects include, quote-unquote, post-operative discomfort. There's got to be a better way. BPH is not inevitable. Most doctors may assume BPH is just an inevitable consequence of aging since it's such a common condition, but that wasn't always the case. In the 1920s and 30s in China, for instance, a medical college in Beijing reported that BPH affected not 80% of male patients, but only about 80 individual cases over 15 years. The historic rarity of both BPH and prostate cancer in China and Japan has been attributed to the country's traditional plant-based diets. Recent studies on Tsimane men, Bolivian subsistence farmers who center their diets around starchy staples like plantains, found that advanced cases of BPH were almost non-existent, confirming its non-inevitability. Population studies suggest that low intake of animal protein and high intake of fruits and vegetables may be protective. Compared to men eating meat less than once a week, those eating meat on a daily basis had more than twice the odds of suffering from BPH-type symptoms. In a more granular study, researchers found that poultry and eggs seemed to be the worst, along with refined grains, but no association was found for red meat or dairy. Of all plant foods, eating onions and garlic has been associated with significantly lower BPH risk. In general, cooked vegetables may work better than raw, and legumes, beans, split peas, lentils, and chickpeas have also been associated with lower risk. Men consuming the isoflavones found in just a cup a day of soy milk also harbored lower risk. Textured vegetable protein, known as TVP, is a soybean product often used in veggie chilies and pasta sauces. Although I prefer less processed soy foods, I would recommend this type of TVP over the TVP used in urology, which stands for transurethral vaporization of the prostate. Plant your prostate. In How Not to Die, I detailed a series of experiments by Ornish and colleagues who pitted the blood of individuals before and after a plant-based diet against cancer cells growing in a petri dish. The blood of men on the standard American diet slowed the growth rate of prostate cancer cells by 9%, but when men followed a plant-based diet for a year, the blood circulating within their bodies could suppress cancer cell growth by 70%, nearly 9 times the cancer-fighting power with a plant-centered rather than meat-centered menu. Similar studies have found that women on plant-based diets appear to dramatically strengthen their defenses against breast cancer in just 2 weeks. What if the same experiment were performed on the type of normal prostate cells that grow to obstruct urine flow? Within just 2 weeks, the blood of men eating plant-based diets acquired the ability to suppress the abnormal growth of non-cancerous prostate cells. What's more, the effect didn't seem to dissipate over time. The blood of long-term plant-based eaters had the same beneficial effect for up to 28 consecutive years, so it appears that as long as we continue to eat healthfully, the rates of prostate cell growth will go down and stay down. However, some plants may be particularly prostate positive. First, a sidebar, though, saw palmetto and a supplement that actually works. Saw palmetto berry is undisputedly the most common herbal supplement used for BPH, but it doesn't work. One supplement that may help prevent and treat BPH, though, is vitamin D. Details on both in c.nf/SAW, S-A-W. Go-to seed. Flax seeds can be used to treat BPH. Men given the equivalent of around 3 tablespoons of flaxseed daily experienced relief comparable to that achieved with commonly prescribed drugs such as Flomax or Proscar, but without their side effects. Pumpkin seeds also work as detailed in c.nf/seeds, and when I say c.nf, I mean see.nf, in this case /seeds, leading the European equivalent of the FDA to conclude that they can be used for the, quote, relief of lower urinary tract symptoms related to an enlarged prostate after more serious conditions have been excluded by a medical doctor, unquote. A sidebar, wee hours of the night. One of the most burdensome symptoms of BPH is nocturia, frequently having to get up in the middle of the night to pee. Common sense might tell us to just try to drink less before bed, but remarkably, there's not a clear association between fluid intake and nocturia. One study of about 150 men did find a correlation between the frequency of nocturia and nighttime water intake, as well as how much water you drink in the 4 hours before bedtime, but another study with more than 1,000 older adults found no relationship between the amount of bedtime fluids and having to repeatedly get up to urinate. I was surprised to learn that fluid restriction has never been properly put to the test. There was a study in which a group of older men averaging 4 Ps a night were told to reduce their daily fluid intake from about 7 cups to around 5 cups, and were able to shave nightly bathroom trips down to 3, but it and other similar studies failed to include a control group to really nail down cause and effect. It's even harder to get people to restrict sodium. Nocturia reviews with titles asking the question, which matters most, the water or the salt? Note that salt intake has been associated with nocturia frequency, presumably due to increased thirst-driven fluid intake. This has led to recommendations to cut down on salt to control nocturia severity, but sodium restriction is hard to study because compliance is notoriously poor. You can, however, compare the change in nocturia episodes of those who successfully cut down on salt intake versus those who didn't. Based on that, it appears that even cutting back on as little as half a teaspoon of salt a day may reduce nightly episodes by 40 to 60%. Evening protein intake may also contribute to nocturia. The main determinant of urine concentration is not sodium, but urea, which is a breakdown product of protein excretion. Protein-rich suppers were found to correlate with excess overnight urine production, leading to the as-of-yet untested conclusion that a, quote, reduction of evening protein consumption may be an effective lifestyle intervention in the management of nocturia, unquote. Hit a sour note. What other foods have been shown to help? Cranberries were evidently used by Native Americans to treat urinary ailments. Cranberries can successfully shrink rodent prostates by as much as 33%, but the first human trial, the effectiveness of dried cranberries in men with lower urinary tract symptoms, wasn't published until 2010. The dried cranberries weren't those sugary, oily craisins, but rather just straight whole cranberry powder. Significant improvements in BPH symptoms, quality of life, and all urination parameters studied were noted for about 3/4 of a teaspoon a day of powdered cranberries. What about less than 1/4 of a teaspoon, or even 1/8 of a teaspoon? Both of those doses beat out placebos for decreasing BPH symptoms. The researchers used a branded supplement, but since it was just straight cranberry fruit powder, you might as well buy it in bulk, which is much cheaper, and just throw it in a smoothie or sprinkle it on some oatmeal. 1/8 of a teaspoon would cost less than a penny a day. A pilot study also concluded that cranberries might prevent recurrent urinary tract infections in elderly men with BPH, but the controlled study lacked a placebo or even randomized allocation, making the findings suggestive at best. Garlic and tomatoes. What about a berry that's a little tastier? Welch's funded researchers put purple Concord grape juice to the test for BPH, but it failed to show any benefit. If cranberries are the most effective fruit, what might be the most effective vegetable? I review trials done on tomato paste and garlic extracts for BPH in c.nf/garlic tomatoes. Unfortunately, they were both before and after studies without control groups, so the purported benefits offer only suggestive evidence.